But when did you first become aware of the first case? What happened to you? What was going through your head when you heard, "We have a case, doctor"?
Yeah. So to be quite honest, we were at a leadership retreat locally, not retreating far, but I got a phone call saying, "Hey, pretty sure we have a kid who may have measles." And so my first thought was, really? I mean, respectfully, but really?
Hello and welcome to the Fire Chief Podcast, the only podcast dedicated to the Chief Medical Officer. I'm your host, Lee Scheinbart, and this podcast features stories from CMOs out on the front lines of today's biggest fires in healthcare today. These leaders face some of the toughest challenges out there, and they have agreed to share their insights with you on this show. Today, our guest is Dr. Lara Johnson, the Chief Medical Officer at Covenant Health in Lubbock, Texas, near the epicenter of the worst measles outbreak in the United States in over a decade. Dr. Johnson was born and raised in Lubbock, graduating from Lubbock High School before attending Texas Tech University, where she earned a degree in cellular and molecular biology. She earned her medical degree from Baylor College of Medicine in 2002 and completed her residency in pediatrics at Texas Tech University Health Sciences Center. Dr. Johnson later started the Pediatric Hospitalist program at Texas Tech in 2005, and then she joined the Covenant Health medical staff as a physician in 2007. She has also completed a fellowship in health policy and health services research through the Yale College of Medicine. Dr. Johnson, welcome to the show.
Thank you so much. Happy to be here.
Thank you. Well, we're going to get right to the heart of the matter. You are recording this with me from your hometown at the hospital you work, correct?
That's right. Absolutely.
You're a native of Lubbock, and how did your family settle in the area?
My grandfather on my father's side came to go to Texas Tech University on the GI Bill after World War II. And so that's how that side of the family arrived in Lubbock. And then on my mother's side, my grandparents were farmers in Oklahoma and then ended up in Lubbock. My parents, they are Lubbock natives, relatively speaking, and then they went to Texas Tech and stayed here. I actually, as most people do, I didn't think I would stay here in my hometown. That wasn't what I thought I would be doing when I was growing up necessarily, but ended up back here for part of my training. And then, I think we should all be focused on caring for our communities, but when that community is really the community in which you've grown up and your family still is engaged with the community, that just takes on an even additional layer of importance.
That is an incredible origin story, and it is the epitome of what it is all about to be a physician leader. Many of us move from our hometowns and become embedded in new communities and take on the mantle of responsibility of leadership. So hats off to you. And I'm especially proud to have you on the show and talk about your community. And we're going to get into that in just a moment. How long have you been in the role of Chief Medical Officer?
I am just about to have my 18-month birthday. So just a year and a half I've been in this role.
And if you may recall, it was 5 years ago this week that the WHO announced that the world was officially experiencing a pandemic. So go back in the time capsule and tell us, what was your role in March of 2020?
Yes. So in March of 2020, I served as the division chief for a pediatric hospital medicine team for about 10 to 11 years prior to jumping into this role as CMO. So I was kind of in the middle of my leadership tenure in that space as a faculty member at Texas Tech School of Medicine. And I also was the vice chief of staff, but at that time, the current chief of staff was just transitioning into a new leadership position kind of before his time was concluded. And so I had been the chief of staff at the Children's Hospital for about 15 seconds when the pandemic began, give or take, having assumed that, 10 months earlier than I had thought I would be assuming that role. So that was my pandemic experience. So, I think the pandemic, COVID, obviously was broadly impactful across all of healthcare. I do think as a pediatric hospitalist focused on a children's hospital, we definitely had a different experience and certainly, not the same degree of challenges in the sort of acute healthcare experience as our adult colleagues did. So in some ways, I feel like the pandemic experience was, a little bit less intense on the pediatric side of things. Now, to be fair, not without its challenges. So not to minimize it, but certainly, and especially in the initial waves, the disease burden was so significantly on the adult population.
So while I would absolutely have no choice but to agree with you, I think you are now seeing the after effect because, and I've talked to other pediatric chief medical officers, so it wasn't long after the pandemic, regardless of your role and anybody else's, you began to see raging quantities of RSV in children's hospitals because children were isolated in so many ways during the pandemic for so many reasons, but they had not developed the traditional patterns of exposure to RSV and others. So it became a full-blown outbreak everywhere that it occurred as these young kids then saw it a couple years later with having been isolated. So there's that. And now we're talking about measles. And I say that because we've seen a decline in vaccination rates for 20 years. That is not new. But we are seeing a particular area of concern from a public health perspective, which we'll get into that in a second. So now you are sitting in the epicenter of the measles outbreak in the United States right now. Not the only outbreak we've experienced in the last decade or so, but some are saying this one is the worst of all of them. And I'm wondering if you have any thoughts. Do you consider it the worst, notwithstanding that you're at the heart of it?
Well, I think some of that honestly remains to be seen. At this point, the total number of cases is certainly higher than many of the significant outbreaks that we've seen, over the past 20 years. It's not the highest, but it's also true that we're only 6 weeks or so into this outbreak. What is clear is it is a very significant outbreak with a large number of cases, and that it will certainly be among the worst, if not the worst. And to some extent, it's important to keep that context in mind in terms of, how does this compare? And honestly, just looking for how have other jurisdictions dealt with, outbreaks of this magnitude and those kinds of things. So I think those comparisons are relevant, but it's also true that it sort of doesn't matter if it's the worst or the second worst or the whatever. It's big, it's significantly impactful. It's certainly having a great impact on rural West Texas and on certainly here in Lubbock. And then, we're seeing cases in New Mexico. So it's sort of like you're always a couple of weeks behind in what the data show and then what it maybe feels like on the ground and all those kinds of things. So
Yes, totally honor that point. It is difficult to stay ahead of it, and you can do all of the modeling that you want, but it becomes a reactionary event. Let's just go back a second and we talk about the severity of the outbreak. What is unique is the quantity of cases in the short period of time compared to historical data over the last 10 or 20 years. We might say, oh, here was an outbreak of 180 cases or 240 cases, but that was over an extended period of time. So we have a narrow window. We have a large quantity of cases, and we have two other elements that historians can decide if this was the worst one or not. Number one is what is the level of immunity or vaccination? So that all counties track this, and I know this is true in Texas. There's public reporting of vaccinations that go into a database. So do you know if the Gaines County and other counties have vaccination rates in excess of 95% or below that threshold?
So definitely below that threshold. And, I think the other thing that's true is a lot of the ways that this data is provided is kind of by school district, looking at, percent immunization, completion by kindergarten enrollment as a metric. And I think, the other thing to keep in mind, so certainly in Gaines County, those numbers are lower, and there are some school districts where they're extremely low. That is true. But there are also a lot of individuals who may not be attending public school.
That's right.
And so, especially in more isolated communities, there may be, homeschooling and other avenues from an educational standpoint that won't be reflected in those numbers. So you
combine homeschooling with other educational paradigms and religious exemptions. And so no matter what the number is publicly reported, it's an overestimation of the total population, and it's far less than what we would like to see, which therefore creates the risk of ongoing spread depending on the ability to isolate and contain from a public health perspective. So we may see a higher rate of disease or a larger swath of people affected. And so that, again, historians can determine. But we do know, and it occurred at your facility, the death of a young person. And we know in eastern New Mexico, there was a death, I believe, of an adult. And we don't need to get into the pathophysiology of this. But when did you first become aware of the first case? What happened to you? What was going through your head when you heard, "We have a case, doctor"?
Yeah. So to be quite honest, we were at a leadership retreat locally, not retreating far, but so all of our executive team was together doing some strategic planning for 2025. And I got a phone call saying, "Hey, pretty sure we have a kid who may have measles." And honestly, I mean, I've been in practice for however many years, and lots of people think they have measles, and virtually no one actually has measles, right? So my first thought was, really? I mean, respectfully, but really?
Yeah.
And so, we talked about, well, let's, make sure we do the testing and obviously making sure we had the appropriate infection prevention guidance in place. But, the hope was either maybe this is a random, every once in a while you get a travel related or whatever. There at that time, there had been a case reported, I believe, in Houston. So, there had been one that had been reported kind of earlier in 25. And so my first thought was, okay, well, we'll see. But then I did, get a little more detail that the patient was from Gaines County. And so, knowing some of the populations and some of the vaccination practices in that space, I did have oh goodness, if that's really true, then this will be very concerning. So, that was the initial thought. And then fairly rapidly, within a few days, we had a couple more patients for whom we were concerned for measles. And then I was like, oh my gosh, this is happening. And so, it's still, I think, as with anything, it takes, those initial kind of discoveries take a little bit of time. We're much faster going through all those necessary steps in terms of addressing cases. But from a hospital standpoint, you shift from, okay, we had this one patient and we did the things, to, oh my goodness, we seem to be having multiple. We need to be sure that this is what we're dealing with, but at the same time, we need to get ready to deal with it even before we're sure exactly what it is. So, we were setting up incident command calls, bringing in, the whole house to work on planning and just kind of thinking through while we were trying to discover if that was really, if we were really dealing with what we thought we were going to be dealing with. And so, that's everything from, gosh, we've got to make sure everyone's educated and remembers as to what the PPE expectations are and being in negative pressure rooms and all of those things. But then also thinking about, do we have enough negative pressure rooms? Just the whole host of issues that all sort of bubble up. And then how are we communicating about this and internally and externally? And then, gosh, do we know if our caregivers, that's what we call all of our employed staff or caregivers, okay, we have their immunization information, but how quick and nimble are we in getting to it, right? And then how are we acting on that? And what's the guidance for someone who's susceptible? Anyway, 10,000 questions, right? That all sort of bubble up. And I think our teams did, such a lovely job of coming together to address those things.
And I think you articulated something that I want the audience to pick up on as well. The difference between day-to-day physician practice and then physician leadership is, everybody thinks they have the measles. Let's take a look at the child, right? That's the physician mindset. The leadership is canary in a coal mine, everybody. What do we need to talk about today in case this is patient zero of an event? And do you all have an idea of how it got to your community, or that's an unknown right now?
I think that is still an unknown thing. Certainly lots of epidemiologists and others are working on that. And so that kind of remains to be seen. Yeah. I think it is probably true that there had been some decent amount of disease presence prior to that first case, presenting in our facility, but exactly how much is hard to know, right?
Right. I understand that, and I get that. I think that the other issue is, again, that the subacute awareness, this is the canary in the coal mine. We have to plan for this. We have the muscle memory if it is an outbreak, and something we won't get too far into, but I do think it's worthy of attention. So I'm going to call it out. It is 2025. There are going to be caregivers that work in your environment who potentially were not vaccinated as children for any number of reasons. In all likelihood, your generation, and I'm a bit older, we all were vaccinated. It was not a question mark for a lot of communities. Well, like COVID, we did not have vaccinations for between March and Christmas time. And then even once the vaccinations were available, people did ask for exemptions, and how to have a caregiver who is at risk, a 24, 25-year-old caregiver in your facility who never was vaccinated and has no serologies to show. That's a real challenge. But I just wanted to draw attention to, it's always larger than we really talk about. And I'm impressed that you guys stood up your incident command very quickly and engaged with all of the right people to deal with this. So we don't have a lot of time left, but I have some very, very important questions, and they're very personal. When the patient died, how did that affect everyone, and how did it affect you?
Yeah. So, I think, obviously, I've been in pediatric healthcare for a long time. And unfortunately, we have tragic outcomes that occur because we take care of very sick children in our regional children's hospital. So, on the one hand, every time something like this happens, it is, we certainly have approaches to help support each other and support our teams and, kind of things that we do for any pediatric death, right? And we can always work to do better. And, those are kind of things that from a children's hospital standpoint that we are always reflecting upon and trying to refine and those kinds of things. I think, what is unfortunately different in this case is that the death, really became a media event as well, right? And understandably so. I don't mean to be critical of that. We made a decision to have a press conference later that day. We had been doing, I particularly had been doing a good amount of media. We had a lot of requests, and we felt it was important to communicate both to our local community and more broadly just about what we were seeing and what was going on, for awareness for people who maybe had made a decision not to vaccinate in the past. Understanding the current context might lead people to make different decisions, or at least consider their actions differently. And so anyway, we had a strategy that I would say was essentially almost any reasonable media request. We were trying to accommodate those, but to be fair, there were a lot. And that was taking up a lot of time. But certainly those requests, I don't know, quintupled more than that after the public health authorities reported that there had been a death. And so we made the decision that having a press conference was appropriate, because we wanted to, again, share information. Interest becomes heightened when something so tragic has happened. But also we knew we couldn't spend 50 hours a week doing interviews, and so trying to have a press conference to do that. I will say, one of the things that's hard is I think that was the right thing to do. I don't have any regrets of doing that, because again, the questions were there, the interest was there, but it does lead to people who maybe have a strong perspective in one way or another. The lesson was, don't read the comments on any of the social media sites or things like that. And so not to say that probably some of that wasn't happening beforehand, but I think with heightened media focus also comes heightened focus from all sorts of places. And definitely that's been hard. And I think that's been hard for our caregivers, for our staff as well, right? So, it's never easy to have something really unfortunate happen to a child in our facility. But then when people with agendas on the internet want to talk about it, that is not something we're accustomed to, and it has been a challenge.
So in our training as physicians, we learn how to deal with vulnerable populations, vulnerable individuals, and bad things happen to good people. Bad things happen to bad people too, but bad things happen. And we have the training for that. And I sense how deeply that affects you, and I guarantee it affects the community. I think it's very noble and very, very incredible that your organization chose to be transparent, have the media and answer their questions and meet people where they're at. And the death of any individual should never be co-opted for anybody's personal agenda. So I'll go on record as saying that it's a tragedy, period, and end of story. However, as a chief medical officer and a physician leader, you find yourself in situations that you didn't prepare for, you couldn't have prepared for. I bet you never saw measles. I've been in hospitals for 35 years. I've never seen measles, never saw COVID either, but we learned how to deal with it. Right. So our training helps us get through that. I'm curious, the last 4 or 5 minutes here, what type of training do you wish you had had? I'll give you, for instance, we talk to our medical students, and perhaps your trainees as well, about social media. You and I didn't have that. I didn't, certainly in my medical education. Yeah. We talked to our students about what social media means, the good, bad, and the indifferent from a healthcare and a public policy perspective. So that's just an example. What do you wish you had known about chief medical officer leadership, or what would you tell our audience today about how to be prepared?
Yeah, that's a great question. I think clearly, I told you I don't look at the comments, so I'm not sure that I'm doing it right in the social media space. But I tend to think of media, whether it's traditional or social media, as I think it's really important for physician leaders to engage. I think it's important, certainly in an acute crisis event such as this measles outbreak, but even in general, I think it's important that we're trying to share information and engage with the public, often through some form of media. I will say, as sounding like a hypocrite, however, I tend to think of that as a unidirectional flow, if that makes sense. Meaning, I'm very happy to, be interviewed or engaged with something like that. But I I do not know how to constructively deal with the flow of concerns and sometimes vitriol that flows, in the comment section or in these various places. And so my strategy is to ignore it, which I will say, I'm not saying that's the right strategy. I'm just saying that is my strategy. And I do think in any leadership role, you will have a team, so our media and communications team, they can't ignore it and they do their work in that space. And I appreciate them greatly. And then, and then we kind of go from there. One thing that I've learned through this is, obviously as a physician, and as a hospital, we can't talk about a bunch of things, right? There's a long list of things that we cannot talk about. And that is certainly something that I'm acutely aware of. I obviously cannot go into details about any particular patient, cannot go into details about, the care, cannot go into details about just about anything other than factual statements about diseases and public health and whatever. That I think is something, one of the things I've learned is probably could do a better job of reinforcing that with our internal caregivers. Not to say that they have been taught, I don't mean that, but I just mean being comfortable with that dichotomy of we are going to try to be transparent and to communicate and to be a resource for our community. But at the same time, there's a very clear limit as to what we can say and do in that context, even if others are not bound by such limits and may say any number of things. And I think I've just seen a lot of moral distress in some of our caregivers as they're maybe confronted with these various things that are happening online and in social media and whatever. I think that's hard to sit with. I don't know what we could have done differently, to be honest. And I think during COVID, our healthcare workers took a lot of negativity and anger and a whole host of negative emotions from patients in ways that were maybe different than what we were accustomed to. And this probably falls in the same general area, again, with just there's a lot of strong feelings and perspectives that are pretty outside of what we think of in healthcare and public health. But I wish we could maybe arm all of our teams to be resilient in the face of those kinds of negative influences. But I think that's a real challenge. And I think that leads into some of the wellness challenges that we have. And, again, you kind of framed this as COVID happened recently and now here we are. And I do think, there are going to be long tails to a whole host of things from the way in which healthcare feels like it is can be more polarized in our community than at least I remember thinking it was as I was a young physician and choosing to go into these roles. And so I don't want to be too negative about that. I think it's just another challenge that we have to learn how to deal with. But I do think it's probably important to call it out and sit with it a little bit.
Yeah, there are a lot of learned lessons from COVID, and I'm happy to share some of the information that we used about how to unwind from a crisis and to debrief. So the canary in the coal mine is if your staff is feeling distressed, how do you deal with that in real time, and what are you going to do when it's late summer and this is now an old event and the scars and the wounds and the distress are still there, and there's a series of opportunities to work with the teams and give them the time and space to process what is very difficult. So that was one of the things we learned about COVID, and there are, to your point earlier, there are processes in place to deal with this. This has been one of the most enlightening shows. I think we could go on for another half an hour to 3 or 4 hours. I think you also brought up one of the reasons why we produce this show. There are things that can be said, should be said, and shouldn't be said, and cannot be said. And one of the sacred spaces for physicians is known as the physician's lounge or the doctor's lounge. Yep. And this podcast is dedicated to chief medical officers, and we can consider it a virtual CMO lounge where people can share what they're going through and what it's like, because until you have been in that deck chair you just don't have an understanding of what this navigation feels like and the responsibility to your teams and to your patients and to your community. And so to wrap this up, you all have been listening to the Fire Chief Podcast, the only podcast dedicated to the CMO. If you want to learn more about what it is like to be a CMO, if you're experiencing your own dumpster fire right now, you want to be on this show, email me at Lee Scheinbart or connect with me on LinkedIn. You can listen to the podcast on Apple or Spotify, and you can also watch the videos of the entire shows on YouTube. Our show's website is thefirechief.podbean.com. I love talking with CMOs from all over the United States, so please connect with me, leave your reviews and your comments, and please share this with your colleagues. And in the words of Sergeant Phil Esterhaus, let's be careful out there.